So pelvic injuries are, bit different from other injuries. This kind of injuries are very severe, and it has very high mortality rate, and these injuries are quite life threatening. They sometimes present with life threatening injuries. So if we recapitulate the anatomy, so this is a ring like structure. Okay. So this pelvic ring, basically they connect the axial skeletal with the appendicular skeleton. Okay. So it has two innominate bone, they are joined by the sacrum posteriorly, and in the anterior part it has symphysis pubis, right. So the ilium, ischium and pubis, they all fuse at the triradiate cartilage, and they each have different ossification centers, which usually fuse by the age of 16-18 years during skeletal maturity. So normally anatomically it's a bit elastic structure. Normally the gap in symphysis pubis is less than 5 millimeter, and also the posteriorly this is the sacroiliac joints. Okay. So these two innominate bones, they are joined posteriorly by the sacrum, anteriorly by the symphysis pubis. So this normally in physiological gap is less than 5 millimeter. And this ring structure is stabilized by different ligaments. So this is a busy slide. So the point to remember is there are ligaments anteriorly and posteriorly. In the posterior, ligaments are more stronger because the posterior part of the pelvis is bit more stronger than the anterior part. So in the posterior part it has sacroiliac ligament, in the anterior sacroiliac ligament, it has posterior sacroiliac ligament and the interosseous sacroiliac ligament. In the anterior part it is a symphysis pubis. So there are sacroiliac ligaments, SI joint, and there are other ligaments like this sacrum to the ischial tuberosity, sacrotuberous ligament, and from sacrum to the ischial spine, sacroiliac ligaments in the posterior part, and anteriorly symphysis pubis. The sacroiliac ligaments are there, sacrotuberous and sacrospinous ligaments, and sacroiliac ligaments. So overall these ligaments, they maintain stability of the pelvis and they resist different deforming forces. They resist rotation, they give rotational stability and vertical stability, and they resist deforming forces. And the most crucial is because the pelvis, it contains visceral structure. There are other visceral structures plus neurovascular structures. So to understand the pelvic injury, you must know the anatomy. It has crucial anatomical structure. They are lying very close to the pelvic ring. So there is a common iliac artery. They branches into internal iliac and posterior external iliac arteries. So the branches of the internal iliac artery like superior gluteal artery. So these arteries are very prone to injury and can give rise to severe bleeding. But usually the most of the bleeding is from the venous plexus. There are venous plexus. This is the sacrum. So there are numerous venous plexus over there. So after injury, the most of the bleeding are from this venous plexus. So naturally, because it is close to the visceral structure, bladder and rectum and other structures, so these pelvic ring injuries are often associated with this other genitourinary injuries or some other visceral structures. So these ligamentous structures, bony and ligamentous anatomy, they gives stability to the pelvic ring, and the posterior part is more stronger than the anterior part. Anterior part is bit elastic because during childbirth what happens, it relaxes, but this gives this posterior structures are more stable. Now you have to know the radiographs you should look into to evaluate this pelvic ring injuries. Okay. So if we think, if you think about the NEET PG aspect, so you have to know the different radiographic projections which are important. So first of all, we get usually anterior posterior radiograph, okay, and these two radiographs, one is inlet view and other is outlet view. I will explain it later. So this is the inlet view and this is the outlet view. They are specific to the pelvic ring injuries and they helps us to assess the injury to the different structures as well as the amount of displacement and other details. And this is Jude view. This is specific for the acetabular fracture. So this is the anterior posterior view. You see the injury to the pubic rami fractures is there. You can visualize the sacrum, sacral foramina are there. These are sacroiliac joints, then hip joints. Now inlet projections. Inlet projections, we see the pelvic ring. Okay. So this projection is naturally directed approximately 40° from the craniocaudal direction. Okay. So what we see, if you get this pelvic, this bone model, you can visualize that if you look from above, these are the structures. This is the kind of view you will get. This is a pelvic brim, you see. This is sacrum, sacroiliac joints are clearly visible. Any injury to the sacrum or to the rami, there is a rami fractures, they are visible. And importantly, any displacement happening in the anterior posterior plane, any movement, any instability going, pelvis moving anterior posterior, they are visible with this inlet view. So this we get this displacement, okay, whether it's moving anterior or posterior. The outlet projection is opposite. It is orthogonal to the inlet projections. So the beam is directed from caudal to cranial at approximately 40° to the horizontal plane. Okay, so if we see the pelvis from below, so this is the kind of view you will get. Okay, so you get to see the whole sacrum with clearly visible sacral foramina. Okay, see, these are the sacral foramina. Okay, so pelvis, the vertical displacement of the pelvis moving up and down. So this is more appreciated with these outlet projections. Okay, so the SI joints, sacral foramina you see, and any kind of vertical displacement you assess with these projections. And the CT scan gives more detailed information regarding the fracture morphology, fracture comminution, other details we get to see with this CT scan. So see, if this is inlet projection, so the patient is lying like this, okay, supine, the leg is this side and the head is this side. So inlet projection is, you get, so the beam is like this, going at approximately 40° to the horizontal plane. So you are looking from above, you get to see the whole pelvic brim and whether movement of the pelvis in the anterior posterior plane. Similarly, in the outlet projection is like this, okay, 40° angle, the beam is directed and you get to see the whole sacrum and some vertical displacement of the pelvis. Now, so recently we have 3D CT scan, it gives more details about the fracture types. So the pelvic is the ring structure. So it is stabilized by the bony anatomy and ligamentous anatomy. So like a ring, so any break in the bony or ligamentous anatomy in one part, it is not that unstable, but any ring fails in two locations. So any injury to the ring in two different locations, they give rise to unstable pelvis, right? So maybe it's anterior part, posterior part. So only break in the anterior part, it is usually pelvic injuries is stable. So if the injuries are combined, okay, any break in the two part, so that time this injury become unstable. So the pelvic instability depends on the energy of trauma, this is generally high velocity injuries and other physiological status of the patient. So we have classification for the pelvic injuries. This classification is important too because they helps us predict the hemodynamic instability, which patient will develop hemodynamic instability, which injury is more severe, and we have to focus on this kind of injuries. So, and which kind of injuries are prone for other visceral structure or genitourinary injuries. So, this classification helps us to guide treatment and gives us other details and ideas. So, there are different classification, you don't need to remember all these. The important part is, classifications are based on different concepts. Like tile classification is based on the stability of the pelvic ring. So, the more famous Young and Burgess classification, this is based on the mechanism of injury. Okay. And recently we have OTA classification, it is more detailed classifications, and this is mainly for the research purpose. So, Young Burgess classification, it is based on the mechanism of injury, that means the position of the pelvis at the time of injury, at the time of impact. So, it has different mechanism of injury. One is lateral compression injuries, the impact from the lateral side. One is anterior-posterior compression injury, if there is impact from the anterior-posterior side, or some vertical shear like fall from above, or combined injuries. Okay. So, this is the anterior-posterior injuries. Okay, see, there is a head-on collision with the vehicle. So, there is an impact from the front or from the back. So, what happens? If there is an impact from the front or back, usually this gives rise to the open book injuries. Okay, so maybe for the NEET PG part. So, this is open book means it fails in the anterior part, symphysis, it opens up, and if the injury is more severe, it propagates to the posterior part and it gives rise to the injury to the sacroiliac ligament, and this also opens up. So, like I told you, if this is only limited to this part, it is not unstable, but injury progress to the posterior part. So, if this joint fails, then it becomes unstable, rotationally unstable. Okay. So, it has different grades naturally. Now, lateral compression, impact from the lateral side. What happens? There is a anteriorly there. So, in anterior posterior compression, it opens up. In the lateral compressions, this hemipelvis goes inward. Okay. See, this is going inward. So, what happens? There is an impaction injury on this sacrum or ilium. We get crescent fracture. So, if the question asks, this patient has lateral compression injury or fall from like this or any impact on the lateral side, we have crescent fracture. So, this is a special category, we have crescent fracture. This fracture is like having shape like crescent. So, it is a lateral compression injury. Okay, in the anterior part we might get a pubic symphysis injury or the rami fracture. Okay. Now, vertical shear, it is a very severe injury, as the name suggests. So, the pelvis is injured from both sides, from the anterior, posterior, all the ligaments are disrupted and it is moving up. Okay. So, the whole hemipelvis is unstable. Okay. So, naturally it will have some other hemodynamic instability, vessel injury and everything. So, this is a lateral compression LC. Okay. Different grades are there. As I told you, this is a crescent fracture because there is an impact from the lateral side. So, in the posterior part, there is a crescent fracture. Anterior posterior injury, grade 1, grade 2, grade 3. The higher the grade, the more severe the injury. So, see, in the grade 1, only the symphysis pubis is disrupted. Grade 2, symphysis pubis plus the anterior part of the SI joint. Grade 3, symphysis pubis and a whole SI joint. So, what happens? This one and this ring. So, the pelvis opens up, this is an open book injury. And the vertical shear, anterior posterior part is disrupted and there is a vertical instability. The combined mechanism is, there is a, combination of injuries, usually with the lateral compression with the vertical shear or anterior posterior compression with the vertical shear. So, these combined mechanism injuries are naturally more severe. So, this is the grade, you just need to understand the concept. Lateral compression, different grade, okay. Grade 1, grade 2, grade 1 is stable, grade 2 is, the higher the grade, it is more unstable, okay. Grade 2 is rotationally unstable and grade 3 is globally unstable. Like anterior posterior, grade 1 is stable, grade 2, grade 3 unstable. And this vertical shear and combined mechanism, they are naturally unstable injuries. Okay. So, as I told you, this classification helps us to determine which patient will have severe injuries and other hemodynamic instability. So, naturally, this lateral compression grade 3, anterior-posterior APC injury grade 2, 3 and vertical shear. These are the severe category of injuries, and these are associated with other associated injuries, maybe visceral injuries or hemodynamic instability. So, yeah, combined mechanism. So, you see, the depending on the severity of injury, these patients have the blood requirement or resuscitation requirement. So, in lateral compression 3, vertical shear and APC 2, 3, these are the severe category of injuries. So, approximately we can determine the which patient is requires operative treatment. So, naturally LC1, AP1 stable injuries we can treat conservatively, and other injuries require different kind of stabilization, maybe anterior posterior, that is in post graduation, but you just higher the grade of injuries, the more complex the treatment, and they usually require operative treatment. Now, tile classification, as I told you, it is based on the stability. So, it has 3 types. Type A is pelvic ring unstable. So, it has only part of the pelvic ring is fractured, like maybe iliac wing or some avulsion fracture. So, only one part of the ring is disrupted. So, it is stable injury. Type 2 is, it is rotationally unstable, like open book, okay, lateral compression, okay, and type 3 is globally unstable. So, it is a more unstable. So, it is a degree on it is based on the degree of stability. On the opposite side, the previous classification was based on the mechanism of injury. Okay. So, if we move to the management part, so management is basically pelvic injuries are severe injuries. Once a patient, you suspect a pelvic injury, you have to assess whether this patient is hemodynamically stable or not, whether this patient needs resuscitation or not, whether you need to do something more or not. So, the basic management will progress from stabilization. First, you have to stabilize the patient, because naturally pelvic injuries are high energy injuries, and in most of the injuries they have some associated injuries. So, they are usually seen in polytrauma patients. So, in pelvic injuries, if a patient comes, you focus on the ABC. You know ABC. So, you first secure the airway. Always polytrauma patient, on clinical suspicion, always stabilize the cervical spine. They don't do it, but always secure the cervical spine. You ensure breathing, patient is breathing normally, circulation, and then you assess the disability, and then expose the patient and for the secondary survey. And these injuries are very complex injuries. So, if you don't have the expertise, don't hesitate to refer. Okay. So, clinical assessment. First, you stabilize the patient. The primary survey, you stabilize the patient. This is the priority. You assess whether there are other life-threatening injuries that needs more attention. Whether there is a source of bleeding, whether there is other injuries that those are life-threatening. So, always stabilize the patient. So, do the primary survey. Then you do the secondary survey and try to assess the extent of the injuries and classify the injury. Okay. And with examinations, you evaluate the deformity, the shortening, the soft tissue conditions around the pelvis. Okay. You assess the peripheral perfusion, you assess the pulse of the extremity, whether the perfusion is disrupted or not. So, the priority is first save the life, then focus on the others less threatening injuries. So, stability test, you can palpate the iliac crest. Okay. So, you can see whether the patient is like there is a tenderness or not, and simultaneously you can pull, palpate the iliac crest and pull, give traction to the lower limb to assess whether there is unstable or not. Some injuries are basically when you get the X-ray, some injuries will appear as like a stable injuries, but this stress examination, this is done in the operation theater. So if you stress the pelvis, like if you put pressure on the both sides of the pelvis along the iliac crest, so this is the normal radiograph, okay, inlet view. So after the stress examination, you get this. So the pelvis is moving, okay. So this is the unstable injury. You assess the neurology. So you know the different myotomes of the lower limb, what they do, and always rule out associated injuries, because pelvic injuries, I'm like reiterating multiple times, they are most of the time they are associated with other injuries, chest injuries, other long bone fractures, maybe fracture of the hip joint, fracture of the acetabulum, fracture of the femur, or fracture of the tibia, solid organ injuries, because this is a polytrauma patient. The patient might have some liver injury, spleen injury, some spinal fracture might be there, and other genitourinary injuries. And like the previous slide, the higher the vertical shear injuries, they have higher mortality, higher risk of shock and other associated injuries, and like higher grade of anterior-posterior injuries and lateral compression fractures, they are generally associated with this associated injuries. Now the special category is open pelvic injuries. Like the name suggests, these injuries are like this. The pelvic fracture is associated with any wound that is extending to the colon, rectum or perineum. That means the fracture is communicating with the outside environment, okay. So naturally, since it is communicating with the colon, rectum or perineum, so these are prone for infection and everything. So the soft tissues should be aggressively debrided once you get the patient, and repair should be done as appropriate. And this urological injuries, since the pelvic ring is very close to the urological structures, so often you get bladder injury, urethral injury, injury to the prostate or other structure. So you put the Foley catheter to detect the urethral injury, you get the retrograde urethrogram. You remember, okay, for the PG question, you get retrograde urethrogram to assess whether the dye is leaking in the pelvis or not. If it is leaking, then there is a urethral injury. Then you put the catheter. And there is one suprapubic catheter, because if you can't pass the catheter, you put the suprapubic catheter. Now this is crucial. Why? This is also important once you be orthopedician. Always remember, once you put the suprapubic catheter, try to put it away from the, so this is suprapubic area, right? Try to put away from the pubis, because if you plan to do operation on the pubic, okay, so if you put it very close to the symphysis pubis, you can't operate because this area is contaminated, okay. So you will be doing internship or maybe house trustship. Always remember, because this is very crucial, okay, because most people don't know or don't teach them. So if you need to put a suprapubic catheter, always put it away from the symphysis pubis to keep the area sterile, okay. And this injury, you might get a questions on this. This is a Morel Laval lesion. This is a very devastating injury. You see the pictures over there. So we call it internal degloving injuries. Like, so suppose there is a head-on collision with a car. What happens? The pedestrian, they fall on the ground and got dragged by the on the road, or maybe there are vehicles going over him. So what happens? What the name suggests, internal degloving means the skin and subcutaneous tissues, they got separated from the underlying fascia. Okay, you get it? So normally this is a fascia, this is a skin subcutaneous tissue. This is shearing injury. So if injury is like this, the skin and tissues are separated from the fascia. So this is dead space is got filled with blood, fatty debris and other things. Okay. So why this is crucial? Because since this skin and subcutaneous tissue is away from the fascia and they don't receive the blood supply, so there is a risk of skin necrosis. Now imagine, there is an injury over the pelvis. This patient have this kind of internal degloving, and you need to operate the patient, but you can't operate because the skin is already compromised. Okay. So that's why always look for internal modal level lesion, and they require aggressive intervention. Either you do percutaneous drainage debridement or open debridement, okay, before you go for the operative fixation of the pelvis. So it has high risk of complications because the skin is at risk of necrosis. So there are few radiographic signs of instability. What are those? If you see displacement of more than 5 millimeter in any plane, maybe in the posterior part or anterior part or vertically, okay, there is a posterior fracture gap is there, and if there are in X-ray you see avulsion of the fifth lumbar transverse process or the lateral border of the sacrum. That means this is a sacrum, so there are ligaments from the sacrotuberous sacrospinous ligament. So if the avulsion of the sacrum is there or ischial spine is there, that means they have avulsed from the bone, and they suggest some severe there are signs of instability. So see, this is the inlet view, this is the sacroiliac joint, okay, this is the pelvic brim sacrum. So this joint is starting from this. So this is a more than 5 millimeter displacement. It has gone posteriorly. Vertical displacement is there. This is the level of the iliac crest, and this one hemipelvis, it has moved up. And like this avulsion fractures is there, L5 transverse process fracture is there. Okay. So these are the signs of instability. So it has gone posteriorly. So that's why it has also disrupted. Okay. It is inlet view. As I told, in inlet view, you see, it's a very complex thing. You see like this. So you see the anterior posterior displacement. Okay. So, so this is a, we have to go, and at the end I will get back to this slide. Okay. So in physical examinations, the instability signs are modal level lesion are there. The patient is hemodynamically unstable, and by radiography, the fracture gaps, see the diastasis of the pubis or some avulsion fractures. These are the signs of you have to look for, instability signs. So acute management, again, always focus on stabilizing the patient. After ABCDE, then you assess whether pelvics need some kind of stabilization. Okay. So why pelvics? Because if there is unstable injury, naturally you have to make, stabilize the pelvis. Otherwise, there will be constant source of bleeding, constant injury to the visceral structure or some blood vessels. So what are the methods? Pelvic binder, some kind of external fixator, pelvic packing, or angiographic stabilization, embolization. So you have to identify the source of bleeding. It could be external source or internal, like long bones, abdominal, retroperitoneal, or chest. Now you have to do the test accordingly. If you suspect some abdominal bleeding, you do fast ultrasound. Retroperitoneal bleeding, you get CT scan or some CT angiography. So once you confirm that this is unstable pelvis, the patient has been stabilized, this is unstable pelvis and there is a source of bleeding, then you stabilize the pelvis with these measures. Okay. Either you do external fixation. External fixation means you apply this a temporary frame, metal frame, they stabilize the pelvis. Or there are some pelvic binder or pelvic sheet. What are those? Okay. Patient comes to emergency, you suspect an unstable injury, patient is in shock, you get the radiograph, you see that this is unstable injury, there is lots of gapping, you just immediately wrap a sheet around the pelvis and clamp it. So what it does like this. There is a lots of gap, diastasis is there, SI joint gap is there. This is the unstable injury. The patient is hemodynamically unstable, but once you wrap the sheet, the gap has been decreased. So what it does tamponade effect. So it decreases the volume of the pelvis. So once the volume is decreased, so any kind of oozing of the blood or any bleeding source, so they will be stabilized, right? We have also commercial pelvic binder. This kind of binder, you apply over the greater trochanteric area, but there are risk of like ulcer over there because if you apply it very tightly. So external fixation. What is external fixation? This is the kind of frame. Okay. So the same objective you achieve with a pelvic sheet or pelvic binder. This is a more, if you think that this patient can't be operated in, maybe next 2 or 3 weeks, or this patient needs some kind of more stable fixation, then you apply external fixator. Okay. So this is for the resuscitation purpose, to stabilize the pelvis, to minimize source of bleeding, to decrease pain in polytrauma patient, also as an adjunct to the definitive procedure, okay, or as a rare incidence for as a definitive treatment. Like some patient put suprapubic catheter over there, you can put a plate, then we apply fixator. So the fixator, the main purpose is to temporarily stabilize the pelvis for the resuscitation purpose. Okay. So this is the open book injury. The SI joint disrupted, the disruption of the symphysis pubis, and you apply the external fixator. Okay. So you have stabilized the pelvis. So you compare this with this. The pelvis has been stabilized. So you like stabilize the pelvis, you minimize source of bleeding, and it helps in resuscitation. If like you identify other source of bleeding in the retroperitoneum, then you open up, you go inside, you put some mop and packs over there in the posterior part. Initially I told you the most common source of bleeding from the sacral venous plexus on the posterior part. Okay, they are the most common source of life-threatening bleeding. So if you identify the source, and after stabilization of the pelvis, the patient is not getting stabilized, you have to do this pelvic packing. Okay, so this kind of pack you put and you compress on the pelvis. And the angiography, it could be diagnostic therapeutic. In angiography, like you put a dye, you identify the source of bleeding, and simultaneously you can treat the source of bleeding. So this term you have to know the damage control surgery, damage control orthopedics. Maybe this kind of NEET PG questions you are getting. So damage control surgery is like you are basically this polytrauma patients, you are stabilizing the patients and doing some intervention to temporarily save the patient, basically to manage the initial insult. So if the polytrauma patient comes, patient is in persistent shock. What you do? You apply the binder or external fixation. Even that, if the patient is not getting stabilized, you do laparotomy, you do pelvic packing, and send the patient for ICU. And once the patient gets stabilized, then you do definitive surgery. Right. So this step is damage control surgery. And the definitive management, it depends on the type of fracture you are having, and like I told you, the type of associated injuries, soft tissue conditions, whether patient can be operated or not because of the other injuries, whether the patient has skin are fine or not, there is a moral level elation or not around the zone of injuries, other comorbidities or other life-threatening injuries. So these all play a role in decision making. So generally, if the displacement is less than 1 centimeter, there is a rami fracture with no displacement, and there is no posterior injury, because the posterior part of the pelvis is more stable. So there is no posterior injuries, they can be treated conservatively. And for the other injuries, you do like open reduction, internal fixation. So there are the various means, like you can put a plate fixation, okay. So you can put a screw also, so you don't need to remember everything. In the posterior injuries, there are different kind of construct, There is a like transiliac bars, transiliac plating, SI joint screws. So there are various methods to fix the posterior injuries also. So in conclusion, in pelvic injuries are high velocity injuries, high energy injuries, and always you need to involve other specialties like general surgeon, okay, urology to exclude urological injuries, and some intervention radiology to do angiography and everything, and neurosurgery. So always understand the fracture pattern and see whether these injuries are prone for instability, some hemodynamic instability or not. If you suspect the patient is unstable, have some bleeding, just immediately do something. Apply the sheet, binder, external fixation. Okay, some kind of fixation, maybe external, internal, mainly external. With operation, you do external fixator, or like a sheet or binder to temporarily stabilize the pelvis. Okay, so you have to know the fracture pattern, the patient condition, examination to decide on the next step, and treatment is based on the degree of instability, degree of displacement, and other associated conditions. Okay, so that's all. It was complex, right? So the inlet view. See, this is an inlet view. Okay, you are looking pelvis from above. Okay, so উপর থেকে দেখলে কি বুঝতে পারবো whether pelvis is gone anterior posterior or not. Okay, so this is the kind of picture you get in inlet view, like a ring. And outlet view, this is you are looking like this. So এখানে কি বোঝা যাবে? Proximal cephalad or quadrat displacement. So this is the picture you get in outlet view. So see the difference. Okay, here you get the vertical displacement and you get to see the anterior posterior displacement. Okay, so this anterior posterior view, inlet view, outlet view, these are the three major radiographic projections to you. This gives you idea about everything, about kind of injury. You can classify the injuries and determine which injuries need some kind of special focus or which are most severe injuries. Right? কিছু বোঝা গেল? হ্যাঁ?